In this lecture, we will discuss AV dissociation, including its mechanism, EKG features, and potential causes. Atrioventricular or AV dissociation occurs when the atria and ventricles are under the control of separate pacemakers and beat independently. This results in no relationship between the P waves and the QRS complexes. In other words, they occur independent of each other, with the QRS complexes or ventricular rate being greater than the atrial rate or the P wave rate. Okay, so what you see here is that we have a block going on here where the atria and the ventricles are just separated, okay, beating independently. And we'll see that we can have a pacemaker coming from somewhere in the atria, so here in the sinus node, and then we will have one in the ventricles, maybe from a junctional beat or somewhere within the ventricles itself, okay. And what we're seeing here is that there's the block, so nothing is getting through this, okay, so no retrograde or atrial or anterograde conduction, and we're having them be independently. But in this case, we're seeing that the ventricular rate, so that coming from below this block, the rate will be greater than that coming above. Okay, so we have a greater QRS rate compared to our P wave or atrial rate. Now, failure of rapid ventricular rhythm to conduct retrograde and supersede a slower atrial rhythm does not necessarily imply pathologic disease of the conduction system, as opposed to AV block, in which there's actually a failure of a more rapid atrial rhythm to conduct antegrade and supersede a slower ventricular rhythm. This is an important point. Complete AV dissociation is not synonymous with third-degree or complete AV block. Complete AV dissociation indicates that the atria and the ventricles are completely dissociated. That is, there are separate pacemakers controlling the atria and ventricles without anterograde or retrograde captures. On the other hand, complete AV block is only one cause of complete AV dissociation. And some suggest that the diagnosis of complete AV block or third-degree AV block should be restricted to instances in which the ventricular escape rate is less than 40 beats per minute. Anyways, the main thing here is that complete AV block and complete AV dissociation are not the same, and that complete AV block is a form of AV dissociation. Now, other causes of AV dissociation include sinoatrial block and unusual irritability of the ventricles, such as interference dissociation, secondary to an accelerated idioventricular rhythm or ventricular tachycardia. So what is interference dissociation? Well, first we need to know about something called contradirectional interference. And this is when two stimuli arising in different foci in any region of the heart spread in opposite directions towards each other. Okay, so if you look here, let's just erase what we have going on. We're saying there's two different foci, so imagine this one here in the sinus node, and then we have one here in the ventricles. And now note that they're spreading toward each other, okay, but in opposite directions. So this is heading in that direction, and one is heading in the other direction, okay, from the ventricles. We call this contradirectional interference. And so interference dissociation is simply when there is a repetitive contradirectional interference, which occurs in accelerated idioventricular rhythm or VTAC. Anyways, a little more advanced stuff, but hopefully that makes sense, okay? So let's run through our chart here on this AV dissociation. So again, looking at the regularity, we'll have regular intervals, okay, with our atria and ventricles, but they'll be independent of each other. So if you look here, here's one R wave to the next, okay, so this interval, this R to R interval, it will be the same as these that follow, okay, and then we'll also have an atrial rate, okay, down here at the bottom. There's our P wave that's buried in the end of our ST segment, or T wave, and then we have our next P wave occurring here, and this one that follows, okay. So again, these will be at constant intervals, but again, they'll be independent of each other. All right. Now the rate, we said they're independent, but in this case, compared to our complete AV block, we have an atrial or a P wave rate that is less than the ventricular rate. Okay. So notice that we have more QRS complexes occurring than our P waves. Okay. So we have 4 there. Then if we count our P waves, there's 1, 2, 3. Okay. So we have a faster ventricular rate here. All right. If we're to look at the rate, let's look at the P wave rate, okay? We'll erase this so we can work on something clear, okay? So let's look at the P wave rate. So here's one P wave, and here's the next one, okay? And we'll count the number of thick lines between them. So here's 1, 2, 3, 4, 5, 6, 7, 8, okay? So it's about 8, and if we do 300 over 8. That should give us about 37.5 beats per minute, okay? And then if we look at the ventricular rate from this R wave to the next, so it'd be 1, 2, 3, 4, 5, okay, almost 6. All right, so if we say that's about, let's say 300 over 6 is about 50, okay, somewhere around 50 beats per minute. And we're seeing here that the ventricular rate, about 50 beats per minute, is greater than our atrial rate, okay? So that's just the main point that I was trying to make. In terms of the P waves, we'll have the same morphology throughout, okay, and the axis will be the same. So notice our P wave here is the same as that one that follows. But sometimes we'll have the P waves that are distorted, especially if they overlap with other waveforms, as we saw here, okay? You can't really make out the P wave because it's buried within it. Okay, pretty much the P waves are just marching out at their own rate there. Now, in terms of the P wave to QRS ratio, again, this will vary, but in this case, because we have a faster ventricular rate, we'll have a greater QRS to P wave ratio, okay? So there will be more QRS complexes to P waves because of that greater ventricular rate. In terms of the PR interval, well, in this case, it won't be measurable, okay? We don't have a true PR interval because they're not related to each other, so there'll be no pattern. In terms of the QRS interval, okay, in this case, it really depends on where the origin is coming below the block, okay? If it's coming from, say, this point here, where we have a junctional rhythm, a junctional escape focus, we can have normal QRS complexes, okay? So as we see here, look at these normal QRS complexes that are narrow, okay? And that kind of makes sense because our junctional escape rhythm is usually between 40 and 60 beats per minute, and our rate here was about 50, okay? So right in that range. So narrow QRS complexes if we have a junctional escape focus. Now, if it's coming from the ventricles, so say it's coming from this area down there, we'll have a prolonged QRS interval, okay, because of that slow cell-to-cell depolarization, all right? Now, there will be no grouping as well as no dropped beats, okay? So they're just firing from two different foci that are independent of each other, separate pacemakers. Now, there's also something called isorhythmic AV dissociation. In such cases, there's AV dissociation with sinus and ventricular complexes occurring at the same rate. That is isorhythmic, occurring at the same rate, okay? So iso meaning the same, rate or rhythm, okay? And therefore, the sinus P waves may be buried within the QRS complex or T wave. So if you look here, what we're seeing here is this isorhythmic AV dissociation. We have sinus and ventricular complexes occurring at the same rate. So if you imagine, here's our ventricular complexes, this one here, okay, occurring at normal intervals, but then if you imagine these as P waves that are buried within it, occurring at the same place, okay, the same rate, and we call that isorhythmic AV dissociation. Wide complexes because it's originating within the ventricles, and then we have our P waves occurring at normal rates, okay, so that's called isorhythmic AV dissociation. So the main takeaway that I want you to get from this is that AV dissociation occurs when the atria and ventricles are under control of separate pacemakers and beat independently with a faster ventricular than atrial rate. Well, that's the end of this lecture. We discussed AV dissociation, including its mechanism, EKG features, and potential causes. I hope you learned something.